I thought I would start with the case that originally inspired me to talk about this. And this is a patient that I didn't directly take care of, but who popped up on our list one day when I was rotating at UW. And there were a couple of days where she was on our radar and we weren't sure if we were going to physically consult and actually see her, just coach the team through some communication, but eventually the team did consult on her. So this was a 23-year-old G4 P3 young woman. She is at 32 weeks and 4 days of pregnancy by last menstrual period, with a history of asthma, who was admitted to the MICU for COVID pneumonia in the setting of being unvaccinated. And so just hearing that case, my heart sinks for many reasons. And one of them being just, this ongoing toll that the pandemic has on us and our community. And then also the knowledge of how COVID can be much higher risk in pregnant patients. And then just that thought of how would I deal with this patient if I were the one taking care of her. And so with that said, when you are faced with a pregnant palliative care patient, what are some fears or thoughts that go through your head? And please feel free to just throw them in the chat or holler them out loud. Either one is fine. Hurting not one, but two people. Yeah. The stakes are high when you have one patient. And when there are two, it's even higher, and it's just such a sensitive, it's pregnancy is usually a time of joy and celebration for people who are hoping to have children, and the loss is even higher stakes. It's not commonly encountered, so lots of new info and emotions to process. Yes, so these sorts of cases can have big burdens, not just for the families and the patients, but for teams. This can cause a lot of distress. And yes, things that you don't see very frequently. You might not be as aware of your blind spots or what you don't know. Certainly there are a lot of things to look up, especially medications. Yes, I see this, medications in utero, fetal stress, balancing what medications the mom might need, how they might affect the fetus, whether that's like blood flow to the uterus or teratogenicity. Stress to the family unit. Yes, women maybe I should say persons who are pregnant or at childbearing age may often have other children in the family. So spouses, grandparents, future grandparents, potential siblings may all be affected by this, not just by the danger to the fetus, but then also to the mother who now may not be able to do childcare herself and may be taken away from the family while she deals with her serious illness. Provider and team distress. Yes, yes, there's a lot of room for, I think, moral distress with this case, and then with these cases. And there's a lot of sometimes cultural or religious beliefs that people might have, or political beliefs that people might have, that may feed into how they feel about care that they're delivering or decisions that people make. Okay, goals for both could be mutually exclusive. Yes. Which I think ties into our next comment, potentially complicated ethics. Yes, absolutely. Okay. Well, the good news is I'm hoping to touch on most, if not all, of these topics. And whatever isn't touched on or discussed, we can talk about later in the Q&A section, and maybe process as a group. Okay. And I should say, I think I feel all of those same fears when faced with a pregnant patient. Okay. And so here are my objectives. One, I think I owe an apology to people who have more of a family medicine or OB-GYN background, because my review of pregnancy is probably criminally simplified. But I recognize that a lot of people in the palliative care community might have more of a geriatrics or internal medicine background. And this is a rare case, so good to just go over the basics to have a foundation. Next, I'd like to highlight the ways critical illness may be different in the setting of pregnancy. And then with that background, I'd like to outline the role of a palliative care provider in the care of a pregnant patient, and important questions for palliative care team members to ask. Okay, so here's my review of pregnancy. So when we think of pregnancy, here we have a nice little graphic of a lady as her belly grows, as her pregnancy progresses. It's about a 40-week process, although it can go beyond 40 weeks. And we typically think of this as divided into trimesters. The first trimester is defined by ACOG as beginning with the first day of the last menstrual period and going to about 13 weeks and 6 days, so right up to 14 weeks. Second trimester begins at 14 weeks and runs until 27 weeks and 6 days. And the third trimester begins at 28 weeks and then continues on until birth. The division of the trimesters isn't necessarily mathematically even. And this is in part due to just how the fetus grows and things like viability and how that might affect how we conceptualize stages of pregnancy. First trimester we generally think of as when fertilization occurs and when major organ development happens. Second trimester is a period of rapid growth and development of the fetus. In the third trimester, there's a significant fetal weight increase. And it's a period of organ maturation as the mother and the fetus prepare for delivery. Okay, so starting with weeks 1 through 12, or 1 through 14, if we're going by ACOG trimesters, this pregnancy begins with the first day of the last menstrual period. Kind of strange in some ways, because for the first 2 weeks, I don't usually think of people as being technically pregnant. They have the potential to get pregnant, but fertilization hasn't occurred. Fertilization occurs and implantation occurs sometime around this end of the second week and third week. And by the fourth week, that's when people might begin to notice that they are pregnant. So you might have a missed period and onset of other symptoms, although there's really a spectrum of when symptoms could begin. And around 4 weeks is when pregnancy tests will reliably turn positive. Let's see. And then the symptoms that people have at this point in time are often related to hormone shifts, particularly the spike in HCG that happens the first trimester. And so you'll see a lot of morning sickness, fatigue, dizziness, and I should say progesterone increases at this point also mediate a lot of symptomology. And then from the side of the baby, at the beginning of this, you have a fertilized egg that becomes an embryo, and this is a time of very, very, I should say it's just a very important time for fetal or embryo development. There's gastrulation, where the embryo develops its germ layers, neurulation, where the neural tube forms, and major organ formation. Although organ formation begins in this trimester and continues on and past birth, by the end of this period, the major formation is done, and the organs are already beginning to do, they're already beginning to function often. So with all of the rapid changes that are happening in the embryo or fetus as the transition happens around like 9-10 weeks of pregnancy, this is a time when there's the highest risk of miscarriage, and also a time where fetuses or embryos can be most impacted by medications as far as birth defects go. Towards the end of this period, many women might opt to do a first trimester screening. And so this might be one of the first times where women or persons who are pregnant get some prognostic information about their baby, and if they might be facing any sort of medical diagnoses after birth. Okay, weeks 13 through 27. So this is often considered a golden period for maternal symptoms as HCG related symptoms subside, and before the gravid uterus becomes so big that it causes big symptoms of its own. There are decreased risks of miscarriage after this point, and decreased risks of teratogenicity to the fetus. So from a maternal standpoint, many people go on what they call baby moons and do their travel because this is when they feel the best. And then from a medical standpoint, if there are non-emergent but non-elective surgeries, this is physiologically a good time point where a pregnant patient optimized to deal with that, where you have fewer worries about risks to the fetus, and the maternal physiology is not a very, very gravid uterus. And I think I consider week 20 to be one of the most important points in a pregnancy, for many reasons. For just kind of the average pregnant person, this tends to be a week that is highly celebrated because of the 20-week body scan ultrasound that happens. And so, especially with the rise in the popularity of gender reveals, this is when people will often find out the gender of their babies, because that's when their genitalia is sufficiently developed to be detected on ultrasound. But this is also another time period where potential birth defects can be found, such as spinal cord defects, heart defects. And so this is another important time point in a pregnancy where providers and patients might find out more prognostic and important information about the fetus's health. At week 20, this is also relatively easy for people to estimate because the fundus reaches approximately the height of the umbilicus. And so if you don't know someone's due date, you can estimate if it's before or after 20 weeks by feeling for the fundal height. And if it's at or above the belly button, then it's typically 20 weeks or further. As the uterus gets bigger, you're starting to reach that tipping point where where the size of the uterus can cause issues in a woman. And an important one that I think of is aortocabal compression. So the uterus can, at this point, squish the inferior vena cava enough that it can affect cardiac output. which is important for things like CPR. And so this is an important tipping point. This is also when the fetus enters what ACOG defines as the periviable period. Really commonly, or most commonly in the United States, I would say the viability is somewhere between 22 and 24 weeks, but it depends on state legislature. It depends on what institution you are at and what sort of resources you have access to. And so babies as early as 20 weeks and change, or as late as almost 26 weeks might have the question of viability depending on what is available to support the fetus and mother. Viability has a lot of implications for other things such as abortion. So in Washington state, any individual, and this includes minors, with or without the consent of parents, have the legal right to abortion for any reason before fetal viability, which, as far as I could tell from looking at some of the Washington state abortion websites, seems to be determined to be around 24 or 25 weeks. It's not that you can't get an abortion after this point, but it has to be deemed medically necessary. Let's see. And then viability also tends to carry a lot of ethical ramifications. And then towards the end of this period is when the fetal lungs begin to develop alveoli and produce surfactant. And so that has, I think that's one of the landmarks of the changes that make it a lot more likely that a fetus can survive outside of the uterus. Okay, so weeks 28 through 40, here we are in the third trimester. I think when I think of the third trimester, this is a time where there's increasing impact of the uterus on maternal physiology and symptoms. Just the amount of real estate that the gravid uterus takes in the abdomen can decrease how much lungs can expand. So while, of course, there are hormonal mediated reasons why a pregnant patient might be dyspneic, there's increasing implications from just the uterus. The uterus will squish the rectum and the bladder, and you might see more constipation, frequent urination. With the aortocable compression, there's some postural hypotension that can happen when a patient lies supine compared to in the left lateral decubitus position. They might be more prone to pitting edema in the lower extremities because of the decreased venous return, and just the overall burden of carrying a big 20-something pound bag of tissue and fluid on your stomach can make patients quite tired. Let's see. As the pregnancy progresses, there are also decreasing complications related to maturity in the fetuses. And so I think of this as a period of increasing burden to the mother and decreasing complications to the fetus. So, fetuses who are born before the third trimester, like starting in that periviable period, are sometimes called micropreemies, but starting at kind of the 27 to 28 week mark, they might be termed extremely preterm. Things that fetus born around this time may come up against would be respiratory issues due to lack of development of the respiratory system in the lungs, feeding issues due to lack of development of the GI system. They may not be able to digest milk and may need TPN, for example. Issues with thermoregulation because they don't have much body fat or sufficient neural development to thermoregulate. let's see, there's at very early points, there's risks for cerebral palsy, retinopathy of prematurity as the eyes aren't completely developed yet. And around the 31 to 32 week mark is when babies who are born will still have issues related to prematurity, but they'll typically be able to catch up to their term peers after birth, and will have few long-term effects of prematurity. And ideally, if everyone is healthy, the preference is to let the baby and the mother get to at least 39 weeks, because that's when lungs, liver, brain are most developed. There's still some development that happens out of the uterus, but 39 weeks is ideal. And so maybe a quick review of maternal physiologic changes in pregnancy. Cardiovascular, I think one of the most prominent things that happens is the expansion of blood volume. And this is to help compensate for the increased circuit size with the placenta and the fetus added in to the circulation circuit. Maybe that's a little redundant to say. And then it also prepares for blood loss at delivery. There is a relatively larger increase in plasma volume compared to red cell volume, which leads to a mild anemia and a decreased viscosity that decreases cardiac work. Overall, there's a decreased systemic vascular resistance, an increased heart rate is normal, and the net effect of things usually leads to relatively similar blood pressures. And I mentioned this earlier, postural from aortocaval compression from the uterus. The being in the supine position can lower cardiac output by as much as 25 or 30%. Due to compression of the interior vena cava. And so if a pregnant patient is unstable, just changing their position or manually pushing the uterus to the side can have rapid and significant hemodynamic improvements in the patient. Other changes in pregnancy, as I mentioned earlier, it's normal to be slightly anemic or to have a decreased hemoglobin compared to a non-pregnant cohort. There's often a relative leukocytosis that can get more pronounced as the patient approaches delivery, and women or patients pregnant are increasingly in a state due to increases in procoagulants, and of note, fibrinogen is usually up by like 50%. Respiratory, pregnant women tend to exist in a state of compensated respiratory alkalosis. Progesterone mediates a tidal volume increase by about 40% in pregnancy. And so the rise in tidal volume causes an increased in minute volume, and that lowers arterial PCO2 from in a non-pregnant patient, maybe 30 millimeters of mercury to a mean in pregnancy of, 40 in a non-pregnant patient to a mean in pregnancy of about 30 millimeters of mercury. And then compensation for this respiratory alkalosis usually occurs through excretion of bicarb through the kidneys. Pregnant individuals have increased baseline metabolic needs and oxygen consumption, so they are more susceptible to hypoxia at lower oxygen saturations and over shorter time periods. The increase of blood flow to the head, neck, airway area can make them more prone to airway edema, which can make intubation a lot more difficult. And as the uterus gets bigger, it can make it mechanically more difficult to ventilate these patients. And then kind of in the renal system, there's increased renal plasma flow, and the GFR can increase up to 50%. So with this changes what a normal creatinine is in a pregnant patient. And so the upper limit of normal, depending on the source I read, it can be 0.75 or 0.8. And another thing to consider with this increase in GFR is that this can affect serum concentrations of renally excreted drugs. And so this may affect the dosing. And I guess all I can say there is thank God for pharmacists. So I think I've hinted at a lot of ways just by going over some of those maternal changes or physiology changes. I think I've hinted at ways that this can impact serious illness in pregnancy. To talk about the incidence of serious illness in pregnancy, luckily this is very rare. When I was looking for resources and doing literature searches, there really wasn't a whole lot about palliative care for critically ill pregnant patients. And so after talking to one of our palliative OB colleagues, I was very reassured to find out that that is because this is a very rare occurrence. So ICU admissions will occur in maybe 1 to 10 per 1,000 deliveries, but the majority, somewhere between 63 to 92%, are postpartum. So they're recently pregnant, but the baby is out. And so some of those ethical considerations about worrying about the impacts on two different people are different or out of the equation potentially. The most common causes for ICU admissions are going to be hypertensive disorders, so like preeclampsia and eclampsia, or obstetric hemorrhage, which often happens around the time of delivery. But other things that can happen are sepsis, respiratory conditions, especially or cardiovascular conditions, especially if they have underlying causes, diabetic ketoacidosis, GI disorders like pancreatitis or appendicitis, overdoses or poisoning, neurologic disorders, traumas. I didn't put on here, but traumas can be an unexpected cause for ICU admissions. And malignancy occurs in about 1 out of 1,000 pregnancies. These are breast and cervical cancers, but melanoma, ovarian cancers, and lymphomas are also up there. And as far as these statistics goes, I should also call out that most of the data that I found was collected pre-pandemic. So I'm not entirely sure how the balance has shifted with COVID. Although I'd imagine perhaps ARDS and sepsis might be higher up on the list for causes of ICU admission. And of patients who deal with serious illness in pregnancy, the vast majority of patients that might end up with a palliative care consult, they tend to be later in their pregnancy, but also with a desire to continue pregnancy. So caring for pregnant patients, there are two patients, as people stated earlier. There's the mother and the fetus or baby. And luckily, for the most part, what's good for the mother is what's good for the fetus. So if mom is hemodynamically unstable, she gets some resuscitation, she gets better blood flow to the uterus and the fetus, and it's both sides are happy. But unfortunately, sometimes treatments that help one can adversely affect the other. So for example, a woman diagnosed with cancer like a breast cancer, for example, since that's what's one of the most common things, might be considering chemotherapy or radiation, but then both of those could carry potential teratogenic risks to the fetus or embryo, depending on the stage. And so then this gets into that dilemma we sort of discussed earlier of balancing the two. In general, maternal health is the first priority. So if you can only save one, or if you have to prioritize one, it'll be the mother. And in general, healthcare providers should offer pregnant patients the same standard of testing, whether that's imaging or lab work, same standard of treatments and procedures that non-pregnant patients would be offered. In discussion of how this might affect the fetus, and consideration of ending the pregnancy is on the table. Ending the pregnancy can rapidly improve the pregnant patient's health, and that could be termination of pregnancy, and that could be delivery, depending on what spectrum or how far along the patient is in the pregnancy. And ending the pregnancy, whether it's through termination of pregnancy or delivery, could then free up providers and mothers from kind of an ethical and moral and emotional standpoint to feel better going through with certain treatments like chemotherapy or radiation. And so with this, you can imagine that risk-benefit conversations about continuing versus ending pregnancies are in constant flux, balancing maternal health and prognosis against that of the fetus. As well as preferences of the family. And so gestational age, as you can imagine, is very important in this discussion. In the pre-viable period, so in that 1 to 20, 22-ish weeks, oftentimes this discussion might end up in the favor of just medically aborting the pregnancy if the illness is serious enough. The burden of waiting to go through with treatment might be too much for the mother. For example, a cancer that might progress if you wait several months to treat it. And then the earlier on in the pregnancy, the likelihood that a fetus could be born at term with minimal side effects is lower. Which is not to say that people always go that route, but the balance of things tips in the favor of medical abortion early on. And so when you have a pregnant palliative care patient who is in that pre-viable stage or in the first trimester, various considerations. Diagnostic, things to consider that there are limitations in imaging modalities. So people typically try to avoid ionizing radiation, which often means no CT scans. So ultrasounds and MRIs are preferred. And other diagnostic issues are pregnancy symptoms or changes might mask ominous symptoms. So a lot of pregnant women have changes in pigmentation that might change when someone notices a nevus that actually is malignant, or dyspnea, fatigue, or edema. Well, I guess edema is more prominent later, but dyspnea and fatigue might be explained as part of pregnancy, when in fact perhaps there's a burgeoning malignancy or a blood clot or cardiovascular condition. Prognostically, probably one of the biggest issues is just there's a lack of studies in pregnant women and on fetuses for, I think, obvious ethical reasons. Many times they're excluded from studies because they don't quite fit the population, or things are sufficiently different that you wouldn't want to include them. But then you're not really going to do a randomized controlled trial of certain things with fetuses and pregnant women because of ethical concerns. From a treatment standpoint, early on in the pregnancy is the period of greatest teratogenic risk to the fetus. And so treatments like chemotherapy and radiation, while not completely off the table, in patients who desire to continue their pregnancy, you might put it off or modify what's offered. And then other things to consider at this point would be the effects of pregnancy and pharmacokinetics, kind of going back to changes in GFR, changes in the plasma volume, unbound, amount of unbound drug circulating in the system, et cetera. Later on in the pregnancy, when a fetus is more clearly viable, things might tip more in the scale of favoring delivery, and how much to let the fetus mature before you deliver that fetus will depend on how sick or stable the mother is, and how far in development the fetus is. If it's already 39 weeks, you can just go ahead. But if the fetus is maybe in the 30, 31 week range, you might delay if possible so that you can give them steroids to help hurry along fetal maturation. But the closer you get to having a term delivery, the easier it is to just say, let's deliver the baby and then continue with treatment. And so with a woman who is late in pregnancy, some diagnostic challenges that might happen are anatomical changes can complicate physical exam. For example, a pregnant woman with appendicitis might not present with typical lower quadrant pain. That appendix could be anywhere, honestly. You still have this question of masking ominous symptoms, whether that's edema, fatigue, by pregnancy symptoms that can lead to late diagnosis. Vitals and labs as pregnant patients get later in their pregnancy can often become more and more deranged from what is considered normal in a non-pregnant patient. And so increasingly you might need help from an OB to interpret those labs. And then once the fetus is viable and there's the potential for delivering that fetus, you have to start considering at what point is fetal monitoring useful. And usually you would only do fetal monitoring if you would consider intervening, which is to say delivering the baby, if there were signs of fetal distress. Prognostic issues, many times scoring systems may not account for pregnancy. So for example, QSOFA relies on basic vitals that you can look at. And those are different. Things like respiratory rate, heart rate are different in pregnant people. And so it may be harder for people to diagnose things, and it may be harder for people to plug some of these values into a calculator and know how a pregnant patient is going to do. Things such as tumor markers may not be reliable. For example, in ovarian cancer, I think it's CA-125 is elevated anyway in pregnancy. And then treatment-wise, in these late-term pregnancies, as I said earlier, inducing labor, or in a case of extreme instability, performing a perimortem cesarean delivery, become increasing considerations. You might consider giving steroids if there's time for fetal lung maturation in order to help improve fetal outcomes for an induced labor. And as a pregnant patient and the fetus approach delivery, things that you might need to consider are the effects of that medication at delivery. For example, if you have a pregnant patient with cancer who's being treated for cancer pain with opiates, if they are on chronic opiates, you need to be aware that the fetus upon delivery might develop neonatal abstinence symptoms. Doesn't mean you can't use opiates in pregnancy, but you have to be aware of what could happen with chronic treatment. And then other things like knowing, since we're on this topic of pain, for example, NSAIDs given at the end of pregnancy can lead to premature closure of the ductus arteriosus. And so that can have big effects on the fetus. Is, I would say, pregnant palliative care patient who is in this peri-viable stage. So in kind of that 20 to 31, 32 week area, where it's hard to say whether how burdensome it might be to wait until the fetus is viable. How might waiting affect maternal health? I would say there are a lot of considerations at this point. These include now thinking, what, not just is the fetus viable, but what sort of conditions might they deal with prematurity if they're delivered at this stage, and at what point does the possibility of these complications become not worth it to the parents to try and deliver that baby, versus accepting the risks of potential birth defects or prematurity complications long term. And I think when the decisions are the most gray, I think is when it would be most overwhelming to make these decisions, and when providers can give the least clear guidance on what to do, and when maternal preferences come into play the most. And I think it's important to realize that patients may feel extreme guilt either way. They may feel guilt if they choose to end the pregnancy, but they might feel guilt if they deliver the baby and the baby has long-term health outcomes as a result. They might feel judged by family members. This can cause conflict between partners. And this can also be just the grayness can also be a point where providers might have different opinions from the patient, and there can be increased distress there. And I think it becomes important then to talk very openly with the mother about what their wishes are, with the knowledge that sometimes local legislation or institutional regulations may prevent you from completely going along with what the woman wishes. What I mean by that is, I guess to give some examples, for example, in Texas, if if a pregnant patient is critically ill and loses capacity and has an advanced directive in place, the advanced directive can be or is typically ignored in favor completely of the fetal benefit. And so this can be, of course, very strife with political implications and conflict too. And so it's important in these cases to talk to, it may become important to talk to your ethics team and your hospital's legal team, and to look up what local rules are. Another example might be if your institution is a Catholic institution, there may be different or more stringent requirements around termination of pregnancy and what's deemed medically necessary compared to at a non-religious institution. And so in addition to maternal wishes, there are other stakeholders whose thoughts and opinions matter, although not to the exclusion of the mother's wishes, but the partner, or if it's thought that the mother might pass away, the surviving partner, the grandparents. Typically, in these cases, if the mother does not have capacity, or I guess with any pregnant patient, if the mother does not have capacity, if they're married, the decision-making would default to the spouse. If they're unmarried, typically it'll go to the patient's parents or follow kind of a legal next of kin framework, but things can get messy then if the father of the baby and the parents who are the legal decision makers for the mother and then later the fetus are in conflict with each other. Luckily, it's not usually the case where whoever is making decisions for the mother might be different from whoever is making decisions for the fetus. And so with all of that background, what is the role of the palliative care provider in all of this? I think the most comforting thing in all of this is, while I talked about all of this maternal physiology and gestational age and pregnancy stuff, I think it's important to just have an idea of what goes on, but you'll never actually be the one making all of these decisions all by yourself. Typically in these cases, there might be maternal fetal medicine involved, neonatology involvement, as well as intensivists. You can also lean on your spiritual care, your ethicists, legal teams to help work through, and pharmacists to help work through difficult decisions and decide on things like medications, dosing, et cetera. And so the palliative care provider, typically, I think their most important role will be as a communication expert. So having a good pre-meeting to figure out exactly what providers want to get out of goals of care, conversations, and meetings, and providing support for the patient as well as the family, which of course could include partners, other children, grandparents, and support for the team, because these can be just such emotionally heavy topics. And here's a comment from the chat. I think it's very hard for OBs to talk to young pregnant persons about advanced directives during a time when they may be very excited and especially future and goal oriented. And though I haven't cared for many pregnant persons in the ICU, I have yet to come across a pregnant person who has had an advanced directive. And when I was pregnant, I certainly didn't have one, and the topic was never broached with me. I think that's very accurate. And I think we often don't really talk about advanced directives with patients who are young and healthy, which many pregnant patients are. And so I think that juxtaposition of a very exciting time, or what should be a very exciting time with tragedy makes it very difficult to navigate these conversations. And so here are just some questions that I think are important for us to think about asking during consults. I think the number one that comes up to me is, how will gestational age affect options? So options for ending the pregnancy, whether that's termination of pregnancy or delivery. How does gestational age affect treatment options? Going back to that example of chemotherapy. And then, is the pregnancy far enough along that we're considering delivery? Do we need to think about fetal monitoring? How is pregnancy physiology affecting the patient's medical status and their ability to recover? I don't think I mentioned this, but for example, in ACLS guidelines in pregnancy, after 4 to 5 minutes after maternal cardiac arrest, if ROSC has not been achieved, at that point, it's recommended that a perimortem cesarean section be attempted, just because it can so rapidly turn around physiology. And in fact, it can improve fetal survival and pregnancy survival. And so knowing that the pregnancy itself can be just such a big physiologic burden, understanding how far in the pregnancy the patient is and how it's affecting options is important. And then, are you considering delivery to help her recover or to be able to use different therapies? Are there fetal diagnoses which change the decision making? So whether this is a known diagnosis or the potential for complications with a premature delivery, that's important. And how will those diagnoses affect the quality of life of the family, whether that's the caregiver, say potentially a single parent grieving the loss of their spouse, taking care of a high needs medical child, with potentially a lot of financial and medical bills. Other things to consider are, I think when children have serious illness, I think parents and families often rate quality of life differently than providers might rate quality of life as an outsider looking in. What is the social situation? So who is the patient married? And if they're not, who is the decision maker and who are the stakeholders in taking care of the patient and potentially the child afterward? What is the family situation? How are they being impacted? So are there other children? How is the partner coping? And how are the children coping with a mother potentially taken out of the picture while they're hospitalized? Is there legacy work that you might consider doing for a mother who's about to pass, or for a fetus who might die shortly after being delivered? Does the patient have cultural or religious beliefs that might be impacting their decision making, and which might impact, I think, the degree of guilt they might carry with their decisions going forward, how their family members or cultural community members might look at them and interact with them. I think equally important, do providers have cultural, political, personal, religious beliefs that might be impacting their decision making, and what they offer to the patient, or how they view the patient and how they interact with them, and how much moral distress they might get as a provider because of those differences in beliefs. And then finally, how might local laws or institutional regulations impact treatment decisions? I mentioned things like access to abortions or terminations of pregnancies, but another thing that I didn't know until researching this presentation was in, I think, 31 states. It's think it's 31 states. There's questions of whether or not it's legal to declare a patient brain dead if they're pregnant. Interesting. And also kind of gets you into interesting ethical territory when you're, continuing a pregnancy in a technically brain dead patient and carrying that fetus to term. It can certainly get very, very sticky. And then I guess with the case that we had, I guess in the interest of time, I'll just say she had a worsening clinical status, underwent an urgent C-section on hospital day 2 after getting like several hours, maybe a day of dexamethasone for fetal lung maturation. Unfortunately, the urgent C-section didn't cause any rapid turnarounds in her clinical status. She was extubated initially, but then reintubated for worsening ARDS. And then she had a number of complications, including a PE, DIC, shock, GI bleeds. And then she was discharged to an LTAC with possible locked-in syndrome from just the toxic metabolic insult of everything. And palliative care's role in that consult, having been consulted late enough that she was already maybe a week to several days in. She and her family had already formed a pretty close bond with the MICU and NICU social workers and with spiritual care. So they provided most of the social support, and kind of rallied with the local Buddhist community to coordinate important ceremonies for her. And palliative mainly helped facilitate goals of care discussions and family meetings. Okay, and I think I took you guys right up to the limit of my time. But with that, any questions or things you'd like to discuss? And then I'll just say really quickly, big thank you to Dr. Josie. I actually don't know how to pronounce her last name, I'm sorry. I think Emery. Big thank you to her. She did her palliative medicine fellowship here at UW, and has an OB-GYN background and was able to talk me through a lot of these things and help me streamline my thoughts about caring for pregnant and palliative care patients. Thank you to Dr. Vig, who helped me decide on this as a topic while I was noodling on things and helped me point me in the direction of some really interesting ethical literature about it. And then my husband, Jimmy, I'm pregnant, and my poor husband had to deal with all sorts of like late night morbid musing and verbal advanced care directive issuing when he'd probably rather be sleeping. So bunch of references, and here is a
good decision maker for, I don't know, sorry, that's kind of a convoluted question. And I feel like the answer is probably no, but I was just curious.
Yeah, no, that's an excellent point, and thank you for bringing that up. I did not come across anything in the literature to that end. What happened in the case of the patient that I peripherally saw at UW was luckily the partner and the patient's mother got along reasonably well, and social work helped the father of the baby go through the paperwork necessary to establish paternity, so the testing and paperwork necessary so that eventually the baby could be discharged to the father's care. But I didn't see anything about specifically decision maker arguing that case, but I also didn't do I didn't look at that super duper in depth, I should say.
Thanks.
Well, since the rate of non-paternity is around 2%, unless the mother declares paternity, the father of the baby is not considered.
Makes sense. Thank you.
Thank you for jumping in there.
Well, thank you, Carolyn. Thank you, everyone, for joining. I hope you all have a great rest of your day.
Thank you.